Hello and welcome to the Healthcare Today podcast. Our guests today are Paula Bellostas Muguerza, Global Lead of Healthcare and Life Sciences at Kearney, and Elena Bonfiglioli, Global Business Leader for Healthcare, Pharma and Life Sciences at Microsoft. According to the World Economic Forum, women spend 25% more of their lives in ill health than men. Additionally, only 5% of medicines are properly tested for use during pregnancy. As AI becomes part of everyday healthcare, there's a real risk these tools could lock in that inequality for another generation. Today, Paula and Elena make a compelling case that the path to closing the women's health gap doesn't just run through more funding or policy change, it runs through better data. In an article you wrote for Healthcare Today, you quoted some shocking statistics. Only 7% of global healthcare research funding goes to conditions that exclusively affect women, and just 5% of medicine is properly tested and labeled for use during pregnancy or breastfeeding. To start with you, Paula, when you read a stat like that, what goes through your mind?
I think a bit of rage, Glenn, if I'm honest. And I think it was nearly coming up to 3 years ago that we started to look into this and we were shocked at the time, which is why we started to raise awareness, really get under the skin of the reasons why this is the case. And it's a combination of lack of investment and lack of understanding and lack of awareness and just persistent bias in society towards the role of women. I think what I would like to say is that things are changing and we're starting to see more attention being paid to the fact that we can't just dismiss the fact that women live longer, but they spend more time in ill health and disability. So I'm still enraged about the stats, but I'm a little bit more hopeful that we're going to see some change in the years to come because of the increased awareness and also the fact that colleagues at the World Economic Forum and some consulting colleagues from McKinsey have now understood that there is an economic impact and have been talking about it. So now that we're not just talking about a moral imperative and a social imperative and that we're attaching dollars to it, I'm hoping that we're going to see an acceleration.
Elena, from where you sit at Microsoft, where do these stats tell you about the data that's out there and what can AI glean from that information?
It's a great question. And data, in fact, can save lives. Let me start from there for the population, for every human being. So what the data is telling us is that there is a misrepresentation, there is an underrepresentation, and sometimes there is a secondary consideration. So it is important, it is urgent, and it is really upon us to start treating data as the core infrastructure for the health and the well-being of women. And that is so central because very often we jump into technology, we jump into how we solve the problem. We need to step back and ask, do we have the data to glean the right representation and the holistic representation of the conditions that affect women, the conditions that affect women uniquely, differently, or disproportionately. And if we don't, we should go get the data. And then we can talk as a second step what we can do today with the data, because in the era of AI, today we can really get the insights and scale some of the answers that we don't have. Is it across medical education? Is it across care delivery? Or just understanding a disease with research and development?
We talk a little bit about the perhaps abstract concept of skewed data. Can you make that a little bit clearer for us? What would you say is actually inside a biased data set?
So it goes back to what type of data we have. So who is in the data set? Is it a percentage that reflects the population that we want to study? So if you want to study a condition that even disproportionately affect women, but you do not have a 51% of the data sets like women are 51% in the population, then the who is already skewed. Where is the data collected? And does it reflect correctly the portfolio of conditions in the way they represent the population that wants to be studied? So it's a mix of the who, is a mix of the where is collected, is a mix of does it reflect accurately what we want to study or what we know that needs to be researched. And by the way, just to be clear, technology will mirror what we are trying to solve for. And that's why we need to ask the questions before we apply technology, tools, and solutions. And with that awareness, we can shape data sets through technology that are more inclusive, because maybe some of those data sets can be corrected synthetically.
Paula, talking about the situation we're at now with these data sets, you've walked across numerous health systems. When this incomplete data gets fed into AI tools, triage tools, diagnostic algorithms, risk assessments, what happens to the woman on the other end?
I think we just see, like Elena was describing, just an amplification of the situation today. So we're not correcting the bias that we've had in the system. So, for example, if a woman is presenting with the symptoms of a heart attack, but we haven't educated clinicians, or in the triage algorithms, we are not putting in those sex and gender characteristics of how a woman presents with a heart attack, well, that woman will still get misdiagnosed and will get sent home. And then chances are she's going to have worse outcomes, which is something that we've been seeing for ages, where women are twice as likely to die from a heart attack compared to men, just because we're not having the timely diagnosis. But like Elena mentions, if we are shining a light on the fact that the data that we're feeding into systems today has got a gap and we are able to correct it at source, then those algorithms will actually start by asking, what do you have in front of you? Is there a man or a woman? And then all of a sudden you'll be, okay, so is not the right pain is going to present like you have got gastric problems, and the pain is going to be just central, and you're going to have completely different symptoms, but the system will have already been taught that that is how a woman presents. So I think we have got a fundamental opportunity in our hands if we are able to understand where the gaps exist today, which there are plenty. They are in diagnosis, they are in side effects for some of the medications that have been tested predominantly on men. And if we can correct that, I think this could be a really significant acceleration and we could see some terrific outcomes.
In the article, you dropped another stat. 24% of UK adults are already using AI tools or social platforms for health advice. It seems fairly obvious, but what is the potential effect of so many people asking ChatGPT about symptoms?
Well, first of all, I think that there is a great opportunity for everybody to be much more aware. Because just let me frame it in a very basic way. You could ask somebody, hey, do you know how to treat a headache? And they'll give you the name of the drugs that they use. But if you ask a woman, do you know how to handle your menopause? They kind of look at you and they're lost. There is a serious gap of misinformation, and having the opportunity to use foundation models, AI tools, just to search and understand complex situations, complex conditions, to gather information and then show up in a more informed way for yourselves or for those that you're looking after in your family, with a better understanding of what's going on, and have I would say, a more complete or informed conversation with your doctor, and sometimes being a little bit more challenging in what you're feeling and why you're feeling it, and not being at risk to be dismissed, which is what's happening in the majority of the cases when some of these topics are discussed in medical situations. That's the baseline of the equalizing power of searching for information online. And by the way, we have, for example, in the US, introduced a new patient-facing solutions, which is a health co-pilot. So somebody that works with you as a patient or as a citizen as a tool that is trained in the healthcare domain. And it opens up a whole new equality opportunity and new important dimensions that helps people, and particularly helps women, navigate these complex health information in which oftentimes they're lost just because we're not trained to look at those questions. We're not trained to better understand what are the unique symptoms. And so it allows everybody to arrive to care settings more informed and more prepared to take action.
I think Elena's hitting on something really important there, which is, are the algorithms getting trained on reliable data and solid kind of clinical evidence? And I think this is something that we're starting to see now with ChatGPT Health and Claude Health, that whenever you enter any kind of symptom, they give you a really big disclaimer straight away, as in, I cannot diagnose you, because the data that they're pulling from, I mean, it could be anything, right? It could be good kind of clinical evidence and journals, but it could also be Reddit, where you just don't know what you're drawing from. So therefore, I think there is some risk inherent in this, and I think it's good that they're starting to put these disclaimers, and users need to be aware of the limitations of these tools. But I think as we start to get more specific tools, and this is happening both in the patient domain, that is also happening on the clinical domain, where you've got clinicians now. You mentioned the stats, Glenn, on patients, but clinicians are also turning to large language models to do some of this. And now what we're starting to see is places like Open Evidence, where you're going to be having models on top of really kind of robust clinical data. Eventually, we'll see that sitting also on top of the electronic health record. And that's what we're going to see, like algorithmic medicine really develop. So I think we're at the beginning of it. We need to be cautious because, again, the data that the models are being built on. But as we go towards models that are more specialized, I think the opportunity is really, really significant, because it'll become like, it's just the medical information will become more democratized. And I think we then have got the ability to raise awareness in a way that we haven't been able to do before. And hopefully very quickly, like, channel people towards the right care and the right treatment that they may deserve. And in particularly women, if we are able to make sure that data is not biased.
By the way, we are facing a new generation of these foundation models. It is an AI that is specifically designed for medicine. We should not underestimate the acceleration that can have exactly in these type of situations. This is very different from general purpose technology or general purpose models. These are tools that are trained using biomedical records, clinical documentation, real world patient case studies. And so while they are not yet, with all the disclaimers, diagnosing and so on, but they can interpret much more complicated clinical information and be very much up to date compared to medical education that oftentimes has been disregarding women issues for decades. If not, we wouldn't be at this point with the underrepresentation that the stats have been clearly signaling.
The question of acceleration is very important. Obviously, the benefits are very clear to see, but there is the potential, as you mentioned in the article, for automation bias, where clinicians start to trust the algorithm over their own judgment. From a tech perspective, how do you design systems that ensure humans are kept in the loop in a meaningful way?
If it is for me, Glenn, I would say you have given exactly that answer. Human in the loop is the first design principle. The other thing is responsible AI safeguards. You have to design tools that abide to declared principle. It could be a principle of inclusion, of transparency, of safety, of responsibility, of traceability. All of those. Microsoft has published its 6 responsible AI principles, and that's the way in which we develop solutions. The other thing is observability. As a clinician or as a patient, as a user, I need to be able to understand my sources, to understand the chain of thought of that system that is helping me. So all of those things are definitely needed and must have imperatives, both for those that develop and those that consume the technology.
You both advocate women's health hubs as a model that could really work and help. What do you think is needed to effectively scale them?
I think the model has been proven in a number of places, right? I think in the UK, the work that Dame Leslie Regan has been leading as part of the Women's Health Strategy has been kind of groundbreaking. And at the beginning, it started just with like reproductive health. So if I'm talking to somebody about a cervical smear, can I also talk to them about HPV vaccination? Can I also talk to them about something else? And all of a sudden it's like, well, but you could also talk to them about osteoporosis, depending on where they are in the kind of life course. But you could also talk to them about heart disease. And all of a sudden it starts to become that you're putting the woman at the center. And depending on where they are in the life course, you're putting care around them, regardless whether it is to do with reproductive health or with something else. So I think the model is really groundbreaking and can have a lot of potential. What's getting in the way of scaling is twofold. One, which is the I don't think there was the same level of urgency around the women's health agenda as potentially there was around the reduction of waiting lists in the UK. So therefore, if the advocacy and the policy environment is not there, the funding isn't going to come, and therefore you're not going to be able to scale. So I don't think it's a matter of like the technology can scale or the concept can scale. It absolutely can. It's just that you need the hearts and minds to say this is as big a priority as the waiting lists, and therefore I'm going to put the funding behind it. In places where there isn't a public system, you're starting to see companies that are now super successful, multi-rounds of funding, and will probably IPO, like the case of Maven Clinic in the US, where they're doing absolutely that. So Kate and the team are putting the woman at the center, whether it is a fertility journey or it's a miscarriage journey or it's a menopause journey, and they're wrapping the care either virtually or physically, and they're doing all of the care coordination and the navigation so that the woman doesn't have to spend hours of her life worrying about where do I go next, or worst, because we are terrible at prioritizing ourselves, saying, you know what, I've got too many things to do at work, or caring for parents or caring for children, so I'll just leave that to the side because I come last. And instead of that, they're putting the care in the hands of the woman so easily and so accessible that actually they're seeing just really incredible outcomes and life stories of women whose existences have been transformed. So I think it is totally possible if we put the urgency and the importance of this topic right at the top of the agenda, and then the funding flows.
What role would you say does data have in changing hearts and minds? I mean, stats make a big difference. Just the stats that we've talked about today, they're very eye-opening.
Say that the stats are the signal that something needs to be clearly changed, right? So they are almost like a flashing light calling for action and attention. I would say that attention starts to happen. Action is what we need to fix urgently. And that is where both Microsoft and Kearney, together with many other organizations and supporters, brought the Women Health Tech Manifesto to life, which was launched in January after extensive consultation. The idea was to have an action plan across very specific pillars that go from medical education to R&D and the delivery of care, with indications on what is happening already, where data and AI tools are giving women a stronger voice. And I give you an example. How do you take data and AI solutions to give women a stronger voice at the point of care during the doctor-to-patient consultation or in the exam room? AI clinical assistants today can capture the full context of what the patient, in this case a woman, is saying, the full story, using voice as an attribute and also the underlying data coming from an X-ray or coming from an EMR or coming from social determinants of health. And that exposes the full opportunity of what is needed, looking at a person's condition 360 and taking away biases. And we have ample of examples from rural Georgia into UK or Asia of how some of these systems don't have the bias of the previous medical education, but just simply surface symptoms and nudge the clinician on what could be the cause of what the patient is saying and what the patient is feeling with her unique symptoms and how they should be addressed, proposing exams, tests, or further action.
The Women's Health Tech Manifesto you just referred to calls for women's health data to be treated as core infrastructure. Can we talk a little bit how a health system leader could implement this?
First of all, there are ample examples of how this is already happening. In the UK, our Future Health, majority of the data is women. In the US, Truveta Health is a fantastic example of how health systems are gathering data and using it to make sure that there is health insights, health actions, specific therapeutic interventions that are taking place. In the Middle East, Department of Health have launched a trusted research environment that allows the discovery of medicine aligned to specific therapeutic areas. All of that is built on a new infrastructure that is data, a comprehensive 360 view of the data of the patients. And the question to be asked is, if the patient population is 51% women, does the data follow the same representation? If not, how do we fix it?
Who do you think owns the problem of AI implementation in women's health? Is it governments setting regulations, tech companies building ethically, clinicians demanding better tools? Is it patients advocating, or is it all of the above?
I think it's everybody, Glenn. And I would like to reframe it, like, who owns the opportunity of implementing AI for women's health instead of the problem? It's been a little bit like this whole, how do we close the gap in women's health? It's like this massive elephant that we need to eat. And do we start from the tail or the trunk or the ear? And the reality is that we have to start from all of the places. And it takes a village. That's something that Elena and I have been saying time and time again, which is it is going to take the policymakers to make sure that we've got things that are safe and that are regulated appropriately, but also that we've got the right levels of incentivization for pull through. It is going to take the healthcare system to make sure that we have got the right readiness, but also that we've got the right incentives for adoption, because there will be inertia in using some of these tools. It's going to have to be patients, make sure that we're creating technology that is accessible and we're not just putting it in the hands of like a 1% that has got access to these tools. It's going to be the technology companies like Elena. It's going to be us that are big conveners and that are big accelerators of transformation inside businesses in life sciences, so in pharmaceuticals and medical technology. We're going to have to do this all together. I don't think there is a silver bullet on this.
100% agree. In the end, it's everybody's responsibility because it is about population health. This is not a niche issue. We need to look at it for its entirety, for its opportunity, for its urgency. And with the demographics that we have, with the multimorbidity that we have, with the fact that women are oftentimes both those that deliver care and those that care for the family, this is exacerbating. So it's in everybody's interest to take very specific action and actually take advantage of the new tools. It's the new stethoscope that really allows us to better understand how to tackle women's health, because it's not a problem of lacking the capabilities. It's a problem of reframing the issue and making it a priority for action.
Looking to the future, if the data foundations are solid, AI is deployed thoughtfully, clinicians are supported and not overridden, what does a woman's health journey actually look like from her first period through menopause and beyond? And how is it different from today?
Wow, it's the dream, right? We will have arrived. And I always say this, my daughter's 7 years old. Like, is it going to be really different for her than it has been for Elena and for me? And I sincerely hope so. I'm hoping that the first thing that happens is that whenever she's engaging, the first thing that anybody recognizes is that I have a woman in front of me. And therefore, a whole new way of questioning and a whole new way of thinking about diagnosis and a whole new set of looking at treatments unfolds. Because we have understood that the biology is different and we have the right data and we have the right diagnostics and we've got the right therapeutic interventions. And therefore, the outcomes are there. And she's not left cycling through a system that doesn't have answers and it's just backwards and forwards. And I don't know, God forbid that she's got endometriosis. She doesn't have to wait 7 years until she is able to be treated. Or later in life, she is going through menopause and she's got 17 different symptoms and nobody's really putting it all together and saying, okay, we need to do a therapeutic intervention with HRT. Or lo and behold, she then ends up with a heart attack and somebody is able to spot it straight away. Or even earlier, when she's been going through menopause, they've said, you know what, your lipids are going to go up, so I'm going to intervene now so that you don't have cardiovascular disease. We have got a lot of the information in our hands. We just need to stitch it together and make sure that the interventions are done in the right way. And my hope is that with all of the attention that this topic is getting now, with the fact that investment is going to flow, that we're just going to see a significant acceleration.
So, Glenn, if we do it right, it's a journey that is more informed, is more preventative, is definitely a journey that is ready for the right treatment at the right step of a woman's life. And it's ideally not because of a specific postal code or a specific geography, but it's the new standard of doing care, and therefore is as represented in the world independently of geographic location, postal code, or anything else that still skews outcomes across the world. Because there's not a lack of innovation, it's just a lack of application and representation of those solutions.
Paula and Elena, thank you both very much for your time.
Amazing. Thank you.
Thank you so much. Have a good day.